You've done a good job. Very good job. Oh, thank you very much. Again, it's really a pleasure to be here, and I have to thank for probably the 8th time now Dr. Wyckoff for the invitation to be here. But again, I can't think of a better use of my time for the last 2 days here. It's been really a wonderful experience, and I'm sure this won't be the last time you may see me wandering around campus in future years. Health literacy is a topic that I just believe, to my core, is going to be one of the predominant health care issues that is talked about over the next few decades in this country. And I entitled my talk, Health Literacy, What You Don't Know Will Hurt You, for a very good reason, or maybe 2 reasons. One, to be a little provocative, but the second reason is because it's real. It's true. Approximately 2 months ago, a large study looking at Medicare patients, those are individuals that are 65 years and older, they found out that those patients who had low health literacy were 52% more likely to die. That's the first large study that basically said, if your health literacy skills aren't at certain levels, there is something about that as you engage in the healthcare system that puts you at a greater risk to die. And what was important about this study is that they matched up, or they controlled with a lot of the other variables we know impact on outcomes. They controlled for poverty, for income. They controlled for race and ethnicity. And when they matched up and controlled for those issues, the variable that was remaining was health literacy. And many of the leading health experts, and certainly those that are related or who function in health policy, took note of that and said in many direct ways, this is an issue that we have to address, and we have to address this issue now. That's why I think it is so important. The definition of health literacy is pretty much been a consensus that this is what we're talking about when we say health literacy. This definition is really from Healthy People 2010. The degree to which individuals have the capacity to obtain, process, and understand basic health information and the services needed to make appropriate health decisions. It's a long way of basically saying, health literacy is having the knowledge, skills, and abilities to interact with the healthcare system in a way that you are most prepared to make the decisions that affect your health. Here's some examples, some reasons why this is important. Low health literacy affects patient compliance and medical errors. And I actually like to use the word patient adherence, because to me, compliance has a connotation that someone is willfully not doing something. And what we really found out is that when there were differences in what a physician expected and what the patient did, it most commonly was related to unclear instructions or misunderstanding about what the expectations were. So it's more an issue of adherence, not compliance. And there's a whole body of literature that talks about medical errors and how this is such a pervasive problem in our healthcare system. It's also been noted that individuals with low health literacy have a greater failure to seek preventive health care services at a time where we're pushing the issue of prevention, saying that if you do these things, you have less likelihood to develop certain chronic illnesses. and have touted the benefits of preventive health services, we already know that there's a segment of the population that will not utilize those services because of issues around low health literacy. Chronic disease self-management, oftentimes set of instructions of things that the patient needs to do, certain parameters they need to monitor, and take actions based on the outcomes of the monitoring that can be problematic with individuals with low health literacy. Individuals also have an increased risk of hospitalization. There's a greater difficulty in negotiating the healthcare system. It is difficult for all of us to negotiate that system well. I can honestly say every time I've needed to be hospitalized was a challenge, let me put it that way. And I am probably as familiar with the ins and outs of the system than anybody else, and I felt as though I wasn't quite clear on what I needed to do to make that experience as efficient as possible. And also, some of the research is showing that they also incur higher annual healthcare costs. I'm not going to show a lot of slides, but I did want to show this one slide in particular because it re-emphasized some of the points that I've made about the impact of low health literacy. The first set of bar graphs look at whether or not these individuals took their medications according to instructions. And especially if they took their medication according to instructions, if there were additional requirements for that medication, things like take your medication on an empty stomach, take your medication 1 to 3 hours after your meals. You know, sometimes the prescriptions have, appended instructions. And what this shows is that individuals with low health literacy were only able to follow those instructions about 15% of the time. And what's very striking about this graph is that if you look at the group with high health literacy, they only did it right a little more than 50% of the time. I mean, that light bulb has to go on and say, everything else being equal, we have a problem with communications in the healthcare system when even those individuals that are the most health literate are unable to comply with the instructions around taking their medication. The second set of bar graphs relate to the individual's ability to recognize through monitoring that they have a low blood sugar. These are diabetic patients, and to take the appropriate actions once they have that reading. Poor health literacy, somewhere around 20%, and you can see how individuals with a high health literacy do a much better job of doing that. The last set of bar graphs relate to the ability to understand your rights and responsibilities under the Medicare program. That means being able to take those 10-page forms that they give you, that you sign, and understand all that language and know what you're supposed to do and what the program is going to do. And you can see it's very difficult for people to understand that who have low health literacy. The people with greater levels of health literacy, obviously do a lot better as far as understanding those parameters. The basic framework of health literacy, in my mind, goes something like this. Literacy, which I'll talk about a little bit in a few minutes, but it's really reading, the fundamental reading, writing, speaking, understanding, number, ties into health literacy through the health context and also through the individual dynamics. Ultimately, what you're looking for is the proper health outcome at the end. And when you look at how do you really improve? How do you improve health literacy? It's really done through these four basic, domains. science literacy, fundamental literacy, civic literacy, and cultural literacy. And I'll talk about each one of those next. When fundamental literacy, we're really talking about reading, writing, speaking, and understanding numbers. One of the earlier discussions that I had with some of the students, she asked a question about how do you, grapple with, health literacy when you may be dealing with some individuals, whose, level of reading and writing is relatively low, and how do you move to that next level? And the question she asked is right on point. I mean, the fundamental basis for anything layered on top of that, is basic reading, writing, speaking, those issues. Those issues are things we haven't solved in this country as a whole. And we have to give enough attention to assuring through our educational system that everyone gets those foundations as we look to how do we layer on top of that, the knowledge of, some of the specialized areas that are applicable in health. And that's where you end up into the issue of science literacy, where you're really dealing with, the need for some basic knowledge of, the scientific concepts, the ability to comprehend technical complexity, and also an understanding of technology. We all know that the healthcare system has its own language, has its own culture, has its own way of doing things. Not that those ways all make a lot of sense all the time, but we know they're there. And while it is important for the healthcare system to find ways to be much clearer in how it communicates, it would be unrealistic to believe that there won't be a certain set of vocabulary that's very different from what the average person may engage with in their usual daily activities. Civic literacy is another area, and that has to do with media literacy skills, knowledge of civic and governmental processes. And this one is very, very important. It does require an awareness that the individual health decisions can impact public health. We need for individuals who have certain infectious diseases, for example, influenza, TB, to understand if they have those, they're potentially could be communicable to other people, whether it's in their local family or to other people in areas where individuals may congregate, malls, etc. And so having some type of awareness of those type of issues is important. Final area of cultural literacy. And of course, this becomes more and more important as this country continues to diversify as far as the population and demographic makeup in the country. And these succeeding generation of health professionals that I've met here, the first-year students, clearly will face a nation that is even more, diverse than it is now, and certainly more diverse than it was when I began practicing, 20-something years ago. And these, in my view, are the intervention points. Where do you have, where are the opportunities to have an impact to elevate the health literacy of individuals? Educational system, culture and society, health systems. Improve the health literacy, we can improve the health outcomes. And the reason why these areas of intervention are so important is that I do not believe that we can adequately address this problem by offering another course in the curriculum at this university or any other university. I don't believe that that the attainment of knowledge occurs based on a single a single academic event. I don't believe that that's how human beings learn. I think they learn by continuous, repetitious, repetitive, information stimuli. Now, what do I mean by that? What I mean by that, I think that issues around health need to be integrated in to everything we do as part of the educational system, starting when our kids go to kindergarten. I don't want to see a separate course on health literacy anywhere. What I want to see is that it just becomes second nature and embedded in what we do. And one of the things that I learned when my youngest daughter was transferring between high schools, and I didn't know it up to that point, was that at least in the state of Maryland, I don't know about Tennessee, odd number of years of school is the years they introduce new topics and new concepts. The even number of years they reinforce those topics that they introduced the previous year. So in 9th grade of high school, they introduce a whole new set of concepts and topics, and then the majority of the 10th year is reinforcing, is repeating some of that information, sometimes in a little different way, but then it's reinforcement. 11th grade, new topics. 12th grade, it's reinforcement. And then they come to college and forget everything they've learned since they were born. It seems like sometimes, certainly as far as listening to their parents. So I think that that's really how we learn. And so what I really want to see is those concepts, health concepts, just becoming part of the mainstream. And I'll give you an example of what I mean. I think that in English and learning vocabulary in grade school, maybe the kids should learn how to spell diabetes instead of doorknob. Maybe they should learn, medication instead of sidewalk. When they're doing word problems in mathematics, those problems we all loved so much when we were growing up, instead of talking about the train going down the track at 60 miles an hour, how far will it go, in 45 minutes, I'd love to see a problem that says, John Doe is diabetic. When he measured his blood sugar, it was 300. He gave himself an injection of insulin and rechecked his blood sugar at 10 o'clock at night, and it had dropped by 15%. What is the value for the blood sugar for John Doe? I'd rather that be as one of the options for word problems. So as the students, as the kids, to older kids, to teenagers, to young adults and on, it just becomes second nature. And so when they have to engage in the healthcare system, they're already familiar because they've had a lifetime of accumulation of some of the vocabulary, of some of the terms, and some of the scientific principles. I think in the long term, that's really the only way we're going to have in that the burden of health literacy is not just on the individual. It's not their problem. Well, that person didn't hear my instructions because they're not health literate. If only they would. It's their responsibility too. I don't buy that. I don't buy that. Clearly, there's things that the individual can do and should do to be more health literate because it's in their best interest. Because they'll be able to assure that what things recommend or what they think will happen to them will be what they want. Because they'll be more knowledgeable. But I don't think the system is off the hook. And that there are things to do to be clearer, to be more precise, to be more consistent, to communicate more effectively, that essentially lowers the level of health literacy that an individual needs to be to understand the instructions or the treatment plan. There's things that they can do to make that happen. We can't have a system where the best way you can navigate it, or the best way you can assure you'll get the outcomes you want, or the best way you can ensure that you're making decisions that will be in your best interest, is for you to be, a mini health professional. I mean, do we have to train the nation to be, health professionals or just short of a health professionals? That's madness. That's madness. It's not necessary if we can get the system to speak in plain words, to be clear about what you want, to be clear about what's going to happen. And it's important to note that this issue of the system being clear, and when I mean system, I mean not only the health professional, but the other ancillary structures of hospitals and clinics and all those type of things. That cuts across American society as a whole. It does not relate to the poor. It does not relate to racial, and ethnic minorities in any separate way. It goes across the board. When I went into the hospital, had surgery on my back, all I wanted to know was whether I could see my x-ray. And I can tell you, I had to, what's the right term? Have a discussion with the x-ray, technologist, who kept telling me that he would lose his license if he let me see my x-ray. Now, some might call it an argument, but I think a discussion is more proper. And I mean, it was 45 minutes that we discussed that. And when it was madness. It was madness. He never did give it to me, by the way. And believe me, it was the first thing I said when the attending physician came by. I had it pretty quick because I kept trying to tell him, that really isn't your hospital, that's mine. That's not your x-ray, that's my x-ray. He's like, no, that belongs to us. And I said, no, it doesn't. I said, because you can't share it with anybody unless I agree. So if you can't share it to anybody unless I agree, that makes it seem like that's mine. Because you got to have, if I got to give, I have to give permission for someone to take anything else that belongs to me. So I think that's mine. Now, I'm a health professional, and that was a struggle. I can only imagine what happens to people who don't have that knowledge, who don't have that understanding of the system as they try to navigate it. So believe me, I think a lot of the responsibility, but if you look at it the other side of the coin, the healthcare system can be a hero in this, because there are a lot of things they can do that actually can improve, the ability for people to get the care they need. And that last area of culture and society, I mean, we could, we could talk about that for a whole week, about how important it is to really understand the individual's culture, society, experience, beliefs around health, a whole set of criteria that I think is important to understand as you're trying to engage them to do certain things to improve their health literacy. Because sometimes you may be trying to educate someone around certain factors of health that they don't believe it at all. They have a whole different set of beliefs. And it's not that that's wrong, But sometimes it's, it's important to be able to uncover those things to try to decide what is the direct path to go on issues where you're on polar ends, of the spectrum. And one of the things that, I've always felt is that, health as a whole really isn't a zero-sum game. Meaning, as we help, elevate the health literacy for individuals in the nation who currently have low health literacy, that doesn't mean we're lowering the health of other people. It's just not a zero-sum game. And in fact, it is mine and only my position that if we elevate the health literacy of segments of a population where it's low, that it will not only help them as far as health comes, I think it'll help everyone. Because I think what it'll do, the changes that are necessary to do that will help just make the system more efficient and more effective, and I think everybody benefits in those type of situations. I'm going through a list of recommendations from the Institute of Medicine. The Institute of Medicine is probably the preeminent institution here in this country around, health policy. When they say certain things, people listen. Now, the list is very long. Earlier in the day, I blamed Dr. Wyckoff for having to show all these things, but in reality, I want to show these not because I expect you to write down each one of these, by the time you leave the auditorium, but I wanted you to get a sense of the comprehensiveness of what they think needs to be done to solve this problem. It is a big enough problem for them that they're not 3 bullet points. Most of these bullet points are multifactorial. There are components within them. And so it is an area that is begging for serious, sustained attention. And if I had to boil these recommendations down to just a handful, one of them, the first area is the fact that we need to do everything we can to elevate the health literacy of everyone in this country to the highest level possible. Because we know the higher the health literacy, the greater the health outcomes, and we now have information that basically shows that the greater your health literacy, the less likely or risk you have of death. The second area is there is much more that is needed from a research perspective, especially around the interventions that work to elevate health literacy. There will always be individuals who have ideas of what may work. It is important that we look at those type of interventions where there is evidence, scientific evidence, that they produce the outcome that we're interested in. And that there be much more attention to this area from the policy point of view. What are the broad, overarching goals that are important in establishing for the healthcare system as a whole some type of effort around health disparities? Now, I'm going to talk about one specific example going back to my initial assignment with the Public Health Service on the Navajo Reservation, and do that in the context of what one can learn or how some of these principles affected me when I initially left my residency program to start in my first real job as a doctor. I went out to the Navajo Reservation The Navajo people call themselves Dene. Dene means the people. The Navajos did not name themselves Navajos. There is no such word in Navajo. It is Dene. And the interesting thing about my time there is that the Navajo Reservation, and I'll show you a picture of it in a few minutes, is still relatively high as far as the number of individuals who live a traditional lifestyle. And so I was clearly going into a community of a very different culture from the one that I experienced in Denver, Colorado. I always, whenever I talk about my time on the Navajo Reservation, I always put this picture in, the one on the lower left. That's a Navajo code talker. Anybody here ever heard of the Navajo code talkers? Yeah, most people, a lot of people have. I put that there because I have made a pledge for the rest of my life that whenever I talk about it, I will give them the respect that I think they're due. The Navajo code talkers, in my view, were instrumental in the success in World War II in the Pacific Campaign. Because prior to the Navajo Code Talker program, all the military codes were always broken eventually on both sides. So both sides always knew what the next step was going to be. They knew what the next island was going to be that the U.S. military were going to attack. And, you know, we knew certain things that were happening on the other side. And you can imagine having that information presents a certain tactical advantage. And so there was a lot of discussion about, you know, how to develop some type of code that was going to be secure. And a young, I think he was a lieutenant, had lived on the Navajo Reservation with his parents who were missionaries. And he had this idea of using the Navajo language. Because at that time, Navajo language was only an oral language. There was no written language at all. And it's one that's very, very difficult to speak. I spent 5 years down there, and I can still only count the number of words I can say, and believe me, I tried hard. Very, very hard. It's a very, very difficult language. And so what they did with these 200 to 300 young men was really develop this system where they had codes for all the type of instructions that were important in any military operations. And in many ways, these code talkers was the most valuable person in every unit because they really were the communicational lifeline, you know, across the different units. It wasn't like it was today, and, you know, with cell phones and wireless applications. I mean, communications was an extremely important issue as far as being successful. And one of the reasons why I have so much respect for them is it's really three reasons. One is a fair number of them were captured and tortured, and not one of them ever said a word about the code. Not one of them did. Got to respect that. The second thing is that they were told when the war was over never to talk about what you did in the war. And they were just, I don't know why, maybe, you know, they thought they'd have to use it again sometimes, I don't know. But they essentially were told not to talk about it at all. And for decades and decades and decades, this was kind of, you know, the silent secret, you know, out there on the reservation about what these heroes had really done. And it really wasn't until, you know, the federal government not too long ago publicly really recognized what they had done, where most of the American public got a good idea about what really had happened. And of course, there was the ill-fated movie by Nicolas Cage, who didn't draw much in the box office, but was also tangentially related to the Code Talker program that also heightened some of the public attention. And the last reason why I have a lot of respect for them, and I'll show you a slide, you know, right towards the end, but The Navajo population was almost decimated to extinction by the 1900s. Yet, even in those circumstances, when there was a need for a call to duty, and to do all they could, to support, their home, and this is the home to all of us, they made that call. They answered that call, and really was instrumental in World War II. And the only reason why I really learned about him is that when I moved to the Navajo area, I went to a new hospital, and so there's new housing, and there were all these streets, and none of them had any names. So everybody lived on Hospital Way. And you have to think about your neighborhood where you have all these streets going all over the place. Well, every street there, none of them had any names. So if you wanted to go see someone, you had to try to figure out where they lived. You might have a house number, but you had no idea where they lived. So the hospital decided to have a contest to name the streets. What they said, the only rule was that it had to have something to do with Navajo culture or history. And so there was, people had these nominations, and there was a blue ribbon panel in the hospital to pick out all the winners for the names. And, some of the hospitals, the streets were named Spider Woman Way, Manuelito Highway, all these things. But I lived on 2095 Code Talkers Lane. And I said, what in the world does that Code Talkers Lane? I have no idea what that was. And so I went and asked a Navajo colleague of mine, I don't understand this. What does this mean? And at that point, I got educated and then learned a lot more about it. And I just think it was a wonderful event to really find out what these fine young men did. Very briefly, I worked in Chinle. It's right there. It's right at the center part of the Navajo Reservation. Navajo Reservation is about the size of West Virginia. We had a hospital right in the center there in Chinle. That area on the Chinle Agency is about 3,600 square miles. We were the only hospital. That's it. Every one of these agencies had like one hospital there, and may have had a few surrounding clinics. This is just some of the history. I'm going to skip right through that. There essentially were, agriculture, sheep herders. One of the interesting things is that in 1864, the United States removed everybody from the Navajo Reservation and made them walk over to western New Mexico. And essentially put them in jail in Fort Sumner. The reason they moved them, although one may debate this because I don't think the government has ever officially said why they did it, it coincided with the discovery of gold in the area surrounding the Navajo Nation. And it's interesting that in 1868 they were allowed to return to that land. It also turned out that the amount of gold there wasn't very much. Maybe just a coincidence, I don't know. These were the four sacred mountains where they found some gold that surrounds the Navajo Reservation on all the four sides. This is what I was alluding to. If you look at the demographics, by 1800 there were only 20,000 Navajos left. Today, thank goodness, they have the population has rebounded about 270, and they're probably one of the most populous single, American Indian tribes that we have. This is the hospital I initially worked in. It's kind of a hard picture. Brand new hospital, $20 million, had everything, except automatic bread slicers. We had ER, intensive care unit, inpatient, outpatient, dental, surgery, anesthesiology. We had everything. They had better equipment than my residency program had. It was just stocked with medical equipment. I had approximately 30 health professionals, doctors, and nurse practitioners and PAs with me on that staff there. When I came to the Navajo Reservation, I drove down on a Sunday night from Denver. It's about a 10-hour drive. And when I got there, I was supposed to go work the next day. And when I arrived, a lot of individuals who were there came by and said, hi, welcome, and, you know, good to see you. And when I told them that I was going to an outlying clinic that's about 60 miles away, you know, the next morning, my first day of actual work, there was this awkward silence. You know how sometimes when you're talking in a group and someone says something, all of a sudden everyone stopped talking, and you're trying to figure out, well, what does that mean? It must mean something, but I'm not sure what it means. And it happened several times, so I know I wasn't delusional, or I wasn't sleepwalking. It happened consistently. And so the next day I showed up, you know, to get in the van to drive out to the clinic, and there were essentially 3 of us. I was a physician, there was a pharmacist, and then there was a nurse who was also the x-ray technician, the laboratory technician, and interpreter, and did some other things. And we drive out to the hour, and you know, I'm looking around at the scenery. I had never been down on the reservation before, and we're starting to pass this building that has about 40 people standing outside. And I said, what happens in that building? There's a lot of people out there. And then he looked at me and said, that's the clinic. I said, well, what do you mean that's the clinic? He says, yeah, they're waiting to come in to see you. I said, all those people? They said, yeah, and by the way, that's just the morning rush. Now, I have to admit, I came from a residency program where, you know, if I saw, you know, 15 patients in a day, 16, I thought I had worked the hardest I've ever worked in my life. I get to sit down, spend half an hour, and you know, they block us out a half an hour per patient. You know, talk to them, do a good history, just by the books, like all of you are being taught right now. Try to do some active listening, look for cues, you know. And I'm saying, are you kidding? They're like, oh no, you're not kidding. And oh, by the way, most of them don't speak English. And the only thing I could think was, but I don't speak Navajo. Nor does any other people except one other person here who has other things to do too. So, a couple of things came from that experience. First of all, I wasn't a very good doctor that day. And I admit that to myself. And I admit that to myself because I know that when I entered that clinic, the sun was up, and when I left, that sun had been down for a few hours. And I'd seen 73 patients. Now, you can do the math to determine how much time I spent with each patient. But it was even worse than that. I made it very, very clear with the best communication skills I had other than directly saying it, you could have only one problem today. You may be in here because you have 3, but today you really only have one that you want to tell me about. And I want it to be the one that bothers you the most and I can do something about. Because, you know, if they had a toothache, I'm not pulling any teeth today. I left those tools at home. You know, I can't do anything about that. We need to spend time on things I can do something about. Now, I was careful. I wasn't capricious about how I did that. I am convinced 100% I did not send anybody out there who was in danger because I only allowed them to have one problem today. But the point is, that's not the way to practice medicine. That's just not the way to give the type of quality that you're interested in. But I was really put in that situation because there was not a way for me to communicate effectively with those patients. Now, at the end of the day, when I arrived back home, you know, right up the street and around the corner from that hospital, my first inclination was to go in the house, put everything I had back in my suitcase, get in my truck, and drive north. because this is just madness. There is no way I can do this. I will not survive. You know, I had committed to coming down there for 2 years. No, they would be burying me here in Shinley because I just can't do this. 73, you've got to be kidding me. It won't happen. And once that notion quickly fleeted out of my brain, you know, I did feel as though we've got to do something. That this just is a situation that is not beneficial to anybody. I did not want to lose my mind at that stage in my life. I really didn't. And so, and I didn't think that the patients who were coming into our clinics didn't want to get the care they thought they deserved to get. And so, what I was really faced with is how do you make those two ends meet regarding the patient's ability to really interact with the healthcare system and the healthcare system being able to provide the care that was needed. So I had to find some way that we could enhance what the patients would know and be able to do as far as their interaction with the system, as well as improving what the hospital system's ability to really interact and be clear, you know, with the patients in a way that they can communicate in a much more effective way. And this is what we did. We did a handful of things. First of all, I indicated to the clinical director and the CEO at that time that we needed more interpreters. We needed more people who could speak the language. Because usually when patients came in and didn't speak the language and were able to bring someone with them who could, most commonly they were below the age of 12, if you can believe that. And I can tell you, nothing I have experienced in my life as of today is more uncomfortable than talking to a senior about certain health problems through the interpretation of their 10-year-old granddaughter. Now, I can't even imagine how uncomfortable that is for the patient if I'm that uncomfortable in that situation. But it goes beyond that, because there is no way that, you know, me as a healthcare provider can get the information that I really need to make the right decisions as far as diagnosis, as far as treatment, when I'm going through those type of layers, and including dealing with people that I know is not health literate because they're 10 years old. That does not make sense. So I said, we need more interpreters, and we need interpreters. We need real interpreters, not just people who can speak both languages. We need people who also have knowledge of health, the healthcare system, and the things we do. And that may mean we have to train people in those aspects of health before we have them help us in seeing these patients. But until we do that, there's no way we can give the quality of care that are basically needed. That was one thing we did. The second thing that we did was to establish community efforts to help elevate the literacy of the population as a whole. And it was really utilizing, you know, individuals in our hospital structure that had been doing other things. I'm talking about our health education individuals and our community health nursing. A lot of health education, we're doing a lot of things that never really been proven to work. Sending out pamphlets and putting up posters and all of those things. There's very little evidence that that even works. So we said, stop doing that, Go out there and talk to people. Go out there and have groups. Go out there and have educational sessions. Use the facilities we have in the hospital, but do things that will help raise the literacy on the population as a whole. That was important. The third thing we did was we made an acknowledgement. We acknowledged that there was an alternate system of care out there in the Navajo community, the medicine men. It was a full-service system of care, let me assure you. There are people who went there because they knew they were having difficulties with the gallbladder, and they were looking for an alternative other than coming to a hospital for surgery. So any problem anyone had, there was an alternate system of care there. And I have to tell you, some patients came in to see us after going and seeing a medicine man and not getting better. And we made them better. There were some people who came to see us and left to go see a medicine man because they weren't getting better, and they got better. I didn't care whether or not we made them better, or the medicine man better, or whoever made them better. It doesn't matter. The credit doesn't matter. They got better. There's an alternate system of care there. So for us to help elevate the literacy of that population, to help them become, more part of their necessary decision maker or knowledge to negotiate the system, we had to engage them. We had to meet with the medicine men and talk about what we do, what we use, the effects of our medicine on individuals, and ask them to share that type of information with us. When a patient says that they're going out to get this type of ceremony, can you tell us what that means? Can you tell us what herbs you use? Can you tell us other things that you may do during that ceremony? But opening up that dialogue created a situation where we were able to understand, to really be cognizant of that cultural and language part of that population. We had to think about how to communicate in a different way, in a way that is a little more direct, is a little more understanding that if the patient isn't really clear about what we want to see happen or what the treatment plan is, and the expectations aren't matched up, they're going to go to this alternate system of care. And if that did not result in an improvement of the patient's health, they may come back to us, and then we'd have to decide what the next steps may be. And that has really become codified with, now they meet on a quarterly basis. They've been doing it for the last decade, to a sense where there's a much greater understanding among both groups in trying to address the healthcare needs of the individuals on the Navajo Reservation. Is my last slide, which really talks about what's the lessons learned for that experience, and how does it really all relate to the health literacy, and how do those things mix together. What I really learned from that experience is that you cannot provide the quality of services you need and you want unless you address all of the aspects of that individual. You have to know the language. You have to know the culture. You got to know the medical expectations. The heart, the core of quality medical care, in my view, is not whether or not you get the latest MRI or you get to take the most, the latest release of medication that's now on the market. It's the quality of that interaction and communication between the patient and the healthcare provider in the context of how they're going. That patient is going to navigate through the healthcare system.